So,
Started.
Assalamu alaikum. How are you guys doing so far? Uh, I think there are just a few, but it's fine. I hope your preparation and studying is going well. And inshallah, you guys all do great in the exam. So, without further delay, let's just get started. I'm Amr Hajja, I'm a fourth year medical student. And inshallah, today I'll be doing the endophysio questions. The way I divided the lecture is basically I have the question and then like a simple explanation of the answer and the whole concept in general. Okay. So as far as I know, Dr. Yaqeen taught you the lectures and he taught us the lectures as well. So I tried to go back and squeeze my brain a bit and go back to our final to know what were the concepts that we were examined on, and I kind of brought similar concepts, even if not some of the similar questions. Okay, I'm not sure about this year if they told you, but in our year they told us like just to go over ambos questions. We were like so scared of them, and we didn't know what to do. But in the exam, they actually got us some of the questions, not copy paste questions. They might get similar scenarios, but they change the wording and they change the answers so that they make it a bit of straightforward. And I try to do this similar thing in this presentation. So you might find a lot of clinical scenarios, a lot of words, but I'm gonna be digesting them to you so that you can inshallah digest them in a better way and know how to like approach a question when you see it in the exam. So you guys have 10 physio lectures. I brought the questions that are distributed except for the first two lectures because they were straightforward. I just brought a question because I remember this question was a bit confusing. So I just brought one question about the first two lectures. So let's get started. I'm just going to present the question. And if you want to answer in the chat, answer in the chat. If you want to unmute, unmute. It's fine. I don't mind anything. Yalla, bismillah ar-Rahman ar-Rahim. Let's get started. And feel free to cut me off whenever you want. Tamam? So the first question, it's an easy, straightforward. Which of the following is a hydrophilic second messenger that gets activated when a ligand hormone binds the G protein coupled receptor? So take your time and then answer the question. Put the chat here. Okay, here's the chat. Tamam, tamam, tamam. Okay, mashallah, I see a lot of C's. So the correct answer is, yeah, it's C. As you can see from the question, it's just asking you about a hydrophilic second messenger that gets activated when G protein coupled receptors gets when something bites to the G protein coupled receptors. So the only message that we want from this lecture is we have hydrophilic and second messenger. So you guys should know what are the second messengers, and you should know how they're basically subdivided into hydrophilic, hydrophobic, and the gases. So based on the answers here, we have the nitric oxide and reactive oxygen species. They are all gases. PIP3 and DAG are basically hydrophobic, and cyclic AMP is hydrophilic. So the thing that I wanna deliver from this question is I want you to actually know the like the whole name, then know the subnames. What do I mean by this is that know that adrenal cyclase, guanylyl cyclase, and phospholipase C are effectors. They are not second messengers. Know that cyclic AMP, cyclic GMP, PIP3, and DAG are second messengers because we got a question similar to this. They're asking us about second messenger. I didn't know there was something called second messenger and there was something called effector. So I kind of messed up the answers. Tamam. So just know the whole group and then answer the question based on this. It's an easy, straightforward question. Now we'll move on to the second question. Here we go. I put a small like a timer next to me so that we spend like about a minute for each question. Mm-hmm. D, D, okay. D, mashallah. Okay, guys, anyone wants to unmute to explain the question? It's fine. If it's up to you. If you want to unmute and explain, you can go ahead. If not, I can explain it quickly. طيب يلا I'll go. So a previously healthy 46-year-old man, طبعا the correct answer ما شاء الله it's D, correct? So the question is asking you, is telling, let's just dissect the question more. As a 46-year-old man comes to the physician, 8-month history of headache. So we have headache. Anything might cause a lot of diseases, a lot of things that could cause headache. So, okay, let's just mark it down as headache. We have headache. Blood pressure is 151/92. It's kind of elevated. It's elevated, actually. Examination shows enlargement of the nose, forehead, and jaw, hands, fingers, and feet. So we have the second thing here is the enlargement of all of these things. Ophthalmologic examination shows impaired vision in the outer peripheral fields. So do you know what's the name of this thing, which is basically the impaired vision on the peripheral fields? It's 2 words. Just type it in the chat. It is, okay, mashallah. Bitemporal hemianopsia, laboratory studies show elevated serum glucose. So from this question, we know that we have bitemporal hemianopsia, we have headache, and we have the enlargement of these stuff, which is like, this is the most important thing for us. So bitemporal hemianopsia, headache, this tells us that there's something that's compressing. A lot of factors could result in compression symptoms, for example, bleeding, but the one that we know in endo basically is the tumor. So, or an adenoma, pituitary adenoma. So enlargement of the pituitary gland, compressing on the optic chiasm, causing the bitemporal hemianopsia, and also it's causing headache. But here we have enlargement of the nose, forehead, jaw, and hands. Can you tell me what's the name of the hormone that could cause these symptoms? Of course, it's a growth hormone. Tamam, mashallah. So you guys know basically what's behind this question. Let's go quickly and go ahead and talk about the pituitary a bit. The reason I put this slide is because I want you guys to know the histology of the pituitary gland. It's important. It's very important to know which one is the anterior pituitary and which one is the posterior pituitary. Anterior pituitary is always kind of darker than the posterior pituitary. Tamam? Because they might get you a scenario and then just ask you mark or point which of the following structures might be affected or might be damaged or causing the symptoms. So anterior pituitary is this one. This is the one, the posterior pituitary. One more thing to know about the anterior pituitary is that it is derived from the oral ectoderm, which is the Rathke's pouch. This is a high yield information. Posterior pituitary, it's basically derived from the neuroectoderm. Now, going to talk about the anterior pituitary hormones, it's flat pig, self-explanatory, B flat, basophils, and acidophils. Basophils, flat, FSH, LH, ACTH, TSH. Acidophils are the prolactin and growth hormone. So these are the most important things to know about the pituitary gland. Just review them like before the exam. Now to talk about the growth hormone. Here's the growth hormone. Just know the mechanics of the growth hormone and what are the factors that are increasing the production of growth hormone. Basically, growth hormone is needed whenever we want to grow, whenever we want to like, just think about it, grow, being strong, and these kinds of things. Tamam? So for example, we have stress needs a strong people. So just increasing growth hormone. Puberty, of course, there will be an increase in growth hormone for to grow, to be an adult, and these kinds of things. Exercise increases the growth hormone. And one more thing to know is hypoglycemia. I'm not sure if it's that high yield, but just put it in the back of your head because there are certain level of hormones that are going to be elevated in case of hypoglycemia. One of them could be the growth hormone. Okay. So GHRH coming from the hypothalamus, going to the anterior pituitary, stimulating the somatotrophs, resulting in the production of the growth hormone. Now, we said growth hormone. Why do we need the growth hormone? To grow. So what's going to be the effect on the bones and muscles? It's going to be like to make them bigger and bigger and bigger. How can we do this? Like, just think about it in your head. So we need protein. So it will result in increase in protein synthesis. This is happening by increasing the amino acid uptake, increasing protein synthesis. To grow and to be a bigger, do we need more DNA transcription and translation and protein synthesis or less? We need, of course, more. So they're all going to be elevated. Chondroitin sulfate and collagen are part of the extracellular matrix, so we need more of them. So they're going to be elevated, and cell size is going to be elevated. So what I need you to know from here is that you could get a question, a whole clinical scenario, And then they're mentioning that there will be an increase in growth hormone. Which of the following sentences is going to be correct? So they might mention, for example, decrease in protein synthesis, decrease in amino acid uptake, increase in lipogenesis, not lipolysis, lipogenesis. And the last choice is an increase in DNA and RNA synthesis. So the answer is going to be DNA and RNA synthesis. Tamam? If you can't memorize them purely, just understand them. So this is the message from this slide. Now, going back to our question here, which of the following findings is most likely to confirm the diagnosis? We know that it is an excess of growth hormone. Growth hormone acts on the liver, increasing the IGF-1 or somatomedian. IGF-1 or somatomedian is the one that's deriving the effects on the bones and the muscles. So whenever we have an increase in growth hormone, IGF-1 is going to be increased. And it's the one that's causing the feedback inhibition to decrease the production of growth hormone. Okay, so whenever we want to measure growth hormone levels, we do measure them in the blood. However, we do also measure IGF-1. So what will be happening to IGF-1 levels or somatomedian? They're going to be elevated. Tamam, clear? Is this question good? Do you have any questions? Or do I move? Clear, okay. Let's move on to the second question. I'm going to be quiet. No, I don't want to distract you. So just read the question and try to answer it. Okay. We got an answer, another answer. Mm-hmm. 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 So we kind of have a conflict between E and A. Tamam. So can someone unmute and tell me why would it be E and why would it be A? Okay, I'm just gonna go ahead. So let's just I'm just gonna read the question. Tamam. Okay, this is a valid answer. Okay. I'm gonna read the question and we can know from the question why would it be A or E. So let's just go ahead and see. A 39-year-old woman is brought to the emergency room because of severe sudden onset throbbing headache and double vision for 1 hour. She says that she has been having frequent headaches and has not had her period in several months. Her blood pressure is 93/61. Visual field testing shows decreased visual acuity and loss of peripheral vision in both eyes. Which of the following is the most likely diagnosis? Okay, so here in this question, now we know that based on the symptoms, we have severe sudden onset throbbing headache. So a sudden onset throbbing headache, double vision for only 1 hour. She says that she has been having frequent headaches and has not had her period for several months. Okay, so her blood pressure is kind of low. Visual field testing shows decreased visual acuity and loss of peripheral vision in both eyes. Which of the following is the most likely diagnosis? Now, the correct answer of this question is basically A. However, I'm not going to say that E is wrong. Why is the correct answer is A? Because the symptoms are so the answer could be E, but if a certain thing was not mentioned in the question. Because in the question, they mentioned that there was a severe sudden onset throbbing headache and double vision for 1 hour. So there's something that is acute and a sudden onset that happened that led to these symptoms. Okay. However, she has been having frequent headaches and didn't have her period for several months. This indicates that this is a prolactinoma. I agree with this 100%. But what is the thing that caused the symptoms that are happening now and newly, it's basically the pituitary apoplexy. Now, I'm just gonna talk a bit about the pituitary apoplexy and how can we know that it is pituitary apoplexy. Pituitary apoplexy is what's happening in pituitary apoplexy is that there is a sudden hemorrhage that's happening in the area of the pituitary gland. Why does it happen? Because a previous cancer was there, a tumor was there, which resulted in an increase in the pituitary gland size. And other than the increase in the pituitary gland size, there is an increase in the blood supply to the pituitary gland. So there is the formation of new blood vessels. These blood vessels will be damaged for any reason, could be damaged because they're very fragile, which would result in their bleeding. So this could cause basically the symptoms that could be happening because of the bleeding, which is the effect like on the surrounding of the pituitary gland. So these symptoms could include a sudden onset headache and double vision because of the compression on the oculomotor nerve and because of the basically increase in the intracranial pressure that's happening due to the bleeding, which would cause headache, double vision. And one third symptom, it's going to be the bitemporal hemianopsia. Here in this question, they mentioned bitemporal hemianopsia, and they mentioned that the period was not there. This indicates a prolactinoma because there has to be a tumor that there has to be a previously growing tumor that had rupture, which caused a sudden onset of the symptoms. Okay, am I clear in this question? Like, I wouldn't say that E is wrong. E is right because based on the question, we can say that it is E. It could be E. But however, the thing that caused the sudden onset of the symptoms is pituitary apoplexy. So guys, I understand that this question is kind of confusing. This question, I'm pretty sure that it's not on the level of second year because we actually got this in third year exams and in third year material. But I saw that Dr. Yaqeen put it in the slides and he put pituitary apoplexy and Sheehan syndrome. He got a question about Sheehan syndrome, but I wanted to get another question so that you can get familiarized with two types of scenarios about pituitary apoplexy and Sheehan syndrome. Okay? So just try to memorize what's going to happen in pituitary apoplexy. Are we clear? The guys that put E, are we clear why the answer is A? Hopefully. Okay, alhamdulillah. Alhamdulillah. Tamam. So let's just go ahead and talk about the syndromes quickly. Now, the two and the most important syndromes are Sheehan syndrome and pituitary apoplexy. He told you to stress about these two, so I'm just gonna go over them quickly. Sheehan syndrome, it's happening as a postpartum. So during delivery, sometimes there will be an increase in blood loss. Due to the increase in blood loss, there will be hypoperfusion of the pituitary gland. Okay? So this hypoperfusion of the pituitary gland could cause basically the symptoms that are gonna be happening. For example, they are failure to lactate, amenorrhea, and cold intolerance. So pregnancy usually increases the pituitary gland size. This is gonna happen normally in pregnancy. However, during delivery, there might be a severe loss of blood, which would cause the hypoperfusion of the pituitary gland, which would cause the symptoms. Tamam? So in the question, expect to have a female that is pregnant and delivered a baby. So this is basically about Sheehan syndrome. About pituitary apoplexy, you might have symptoms of an occurring cancer or a tumor, occurring adenoma, but there was a sudden onset of some symptoms which could explain why is it pituitary apoplexy. And the symptoms are going to be headache, visual impairment, and bitemporal hemianopsia, and diplopia due to oculomotor nerve palsy. Guys, I don't think that you need to know cranial nerve 3 palsy and these types of things. Just know it's a sudden onset of headache and diplopia, accompanied by temporal hemianopsia. Clear? And features could be having features of hypopituitarism because of the compression in the pituitary gland. So other hormones could be decreased, which would cause the symptoms. So inshallah, it's clear now. I'll move on to the second. What is diplopia? So diplopia, it's basically, I'm just gonna explain it. Look at my eyes. Now, if I'm gonna look at, for example, to my right side, both of my eyes are going to move to the right side. Diplopia, it's basically when I wanna move to and see a side, not both pupils are gonna move with me. So there might be, for example, if I want to look to the right side, one of the people is going to the right, another one is going to the left. And why is this happening? Because of an cranial nerve 3, which is called oculomotor nerve. You don't have to know the name. It's damaged. This nerve is the one that's responsible for the movement of the pupil, to move it to the movement of the pupils. Okay? Okay, تمام, alhamdulillah. So let's move on. Inshallah, he doesn't get you questions about Shihan and Pituitary actually, because they might be confusing. But if you see a pregnant woman, just put Shihan. Inshallah, and it's Shihan. So let's move on. Bismillah. Another question. Yalla, go ahead. I think this question should be easier to be solved. Okay. So I want someone from the guys that put E in the previous questions now to tell me why is the answer C? Or anyone.
Okay. So, and dopamine will inhibit prolactin, and since it's taking an anti-dopaminergic drug, prolactin is being hypersecreted by the pituitary, and therefore we have hyperprolactinemia.
Tamam. Okay, valid answer, mashallah. So I'll just go over the question quickly. 32-year-old female, persistent lactorrhea, which is discharge of the milk from the breast, has been struggling with infertility. So lactorrhea and infertility for now. Ms. Johnson reveals that she has been diagnosed with the disease. Okay, we don't care. The drug name, we don't know the drug's name, it's fine. But they describe the mechanism. It's an anti-dopaminergic drug. Tamam, so far. What hormonal imbalance might be causing the symptoms? So the answer is C, correct. Now let's just talk about why it is C. Let's just go here. The hypothalamus produces dopamine and TRH, where we don't care now. So let's go to the anterior pituitary. Prolactin is a hormone that is produced by the anterior pituitary gland. Prolactin is not tonically produced, it's tonically inhibited. Why it is tonically inhibited? Because of the effects of the hypothalamus, it's producing dopamine. So the hypothalamus, normally and usually, it is producing dopamine. Dopamine inhibits the production of prolactin. Clear so far? Now, there are two things that are gonna cause, they're the most common things that could cause hyperprolactinemia or prolactinoma, which is basically an increase in the production of prolactin from the anterior pituitary. What are these two things? The first one is the use of an anti-dopaminergic drugs. So whenever we use anti-dopaminergic drugs, now we don't have the effect of dopamine on the anterior pituitary. So what do we expect the anterior pituitary to do to prolactin? It's going to produce it. So it will be produced and it will be secreted from the anterior pituitary, resulting in an increase in the prolactin levels. This is the first thing. So the use of anti-dopaminergic drugs. The second thing is that you might get a scenario which is talking not about an anti-dopaminergic drug, talking about, for example, a trauma or a damage to the brain that affected the vessels of the pituitary gland or the hypothalamus, something like this. So because of the damage, there will be loss of dopamine delivery from hypothalamus to the anterior pituitary, which is basically causing less dopamine, which is causing less inhibition and more of prolactin production. So there will be an increased prolactin. Now, what are the effects of prolactin? There are two main effects of prolactin. The first one is that it enhances milk production, which is causing lactorrhea, which is an increase in the milk discharge. The second thing is that it inhibits GnRH, gonadotropin releasing hormone. This would decrease the FSH and LH. Okay? So there are some side effects. There are some effects that are going to happen as a result of a decrease in the GnRH. In females, we could have, for example, amenorrhea. In males, we could have erectile dysfunction. In both, we could have infertility. Clear? So erectile dysfunction males, amenorrhea females, both infertility, and plus there will be lactorrhea. Now, one more thing could happen in males due to the increase in prolactin effect on the breast. There could be gynecomastia, which is basically increase in the size of the breast. So this is basically what's happening here in terms of prolactin. One more thing about prolactin I want you to know is basically the TRH, which is the thyroid raising hormone, which is produced from the hypothalamus. It enhances the production of prolactin. So in the case that we have a primary hypothyroidism, which is a decrease in the production of thyroid hormones from the thyroid gland, we would expect an increase in the production of TRH and TSH, right? Right. So increase of TRH could cause an elevation of prolactin levels in the blood. Is this point clear?
Yes. When you mentioned the gynecomastia, so that happens when we have extra prolactin in males?
It could happen, one of the symptoms. It's not that of a high yield symptom, but it could happen.
Okay, both males and females, يعني enlargement of the breasts, or just exclusively in males?
In males, it's obviously gonna be obvious
Yes.
for males, but in females, I'm not sure if it's that high yield or it's that obvious because it might not be that noticeable effect.
Okay.
But the main effect in females, it could be is gonna be amenorrhea and lactorrhea. Lactorrhea actually in both males and females because of increase in prolactin. Clear?
Okay, so milk production even in males.
Yeah, it could result in milk production even in males. But like if you don't get a symptom of increase in milk production in males, it could be erectile dysfunction. However,
Alright.
I've seen some questions about increase in milk production in males.
Okay, thank you.
Here, you're welcome. So going back to the question, here we have the symptoms of lactorrhea, infertility, anti-dopamine, anti-dopaminergic, less dopamine, more prolactin in the blood, which is causing the lactorrhea as well as infertility. Hyperprolactinemia is the answer. Is the question clear? Yes. Okay, let's move on. This question might be a bit tricky, but it's fine. Don't worry about it. I brought it just for me to explain it. More than you be able to solve it. It's fine. Mhm. Mhm. Few more seconds and we'll solve it together. Okay. So before me showing you the answer, I'm just gonna like solve it with you guys, okay? So a 58-year-old man comes to his physician because of 1 month history of increased thirst. So we have increased thirst, polydipsia, and nocturia. Nocturia, it's basically when someone wakes up from sleeping to go and urinate. So this could be a sign of polyuria. He's drinking a lot of water to compensate for any dehydration. His brother has type 2 diabetes. Okay. Physical examination shows dry mucous membrane. Dry mucous membrane could be a sign of dehydration. Serum studies show a sodium concentration, high sodium. Glucose is normal, and water deprivation test shows. So, like in terms of this question, you will mainly be able to know it from here. So let me just explain this question quickly. Here we have someone with a polydipsia and polyuria and signs of dehydration. Sodium is elevated. This means that we have a high osmolarity in the blood. Tamam? Tamam so far. So let's move on to talk about the tests. Here we have on initial presentation, serum osmolarity was kind of high or normal, high borderline. and the urine osmolarity is 285. After 3 hours without fluids, so whenever someone without any fluids, what's gonna happen to the ADH? What do we expect the ADH to be secreted or inhibited? When we have someone that have high osmolality as well as no fluids, without any fluids, it's going to be increased, right? Okay, so ADH is going to be increased. Now, what would be the effect of ADH on the osmolality? So ADH drags more water into the serum. So what's going to happen to the osmolality of the serum? Is it going to be increased or decreased? Okay, so we've got one decrease, decrease. Okay, so now we have here decreased. Okay, so far? Tamam. Now, let's move on to talk about the last one, which is the most important one. So far, we know that from here, we know that the effect of ADH is not happening well because the osmolality didn't decrease, it increased. So let's see what happened here. Here, we gave an ADH analog. So we gave a kind of ADH receptor stimulator to the body, to the serum. Tamam? So now what do we expect if we give ADH to a receptor and if it responds, what's going to happen to the serum osmolality? Is it going to decrease or increase? If we give ADH, decreases. So this means, is the receptor of ADH working or not? If we if we give ADH to a receptor and it responded and it resulted actually in a decrease in the osmolality of the serum, is the receptor working? Okay, so now this means that the receptor is working. So now the problem here, is it with the receptor or not? It's not with the receptor. So it's most likely going to be from ADH, because we have a decrease in the ADH levels in the blood, decrease in ADH level production in our body. This resulted in the symptoms of dehydration and increase in the osmolality in the blood. Are we clear? And how did we know this? Because when we gave the patient ADH, it stimulated the receptor and it actually worked. So this means that we didn't have ADH before. Are we clear? All of you guys, are we clear? The rest? It's fine, I can explain it again. So we all agree that C and D, they don't exist because SIADH is not going to cause the symptoms of dehydration, thirst, and nocturia. And the serum osmolality will be way decreased in SIADH. Tamam? Okay, so the answer is A. We knew why the answer is A. I know this question is a bit hard. Don't be stressed out. It's fine. It is hard. I'm not lying. But I saw it in the slides, and I remember it was an important concept when we had our exam. So I kind of brought this question about it. So the two messages that we need from this slide is to know the symptoms of diabetes insipidus, which is thirst, polydipsia, and polyuria, and to know that we have two types. We have central and nephrogenic. How to differentiate between them is that by this test. When we don't give the patient fluid, we expect the ADH to be produced, increase in production. As a result of this, the normal effect would be a decrease in the serum osmolality. Clear? Here, the serum osmolality didn't decrease. So we didn't have any production of ADH. Clear so far? But when we gave ADH to the patient responded, and actually the serum osmolality decreased. So we know that the problem is with the ADH levels, and ADH is not there, so it's central diabetes insipidus. Now, moving on to talk about the ADH. The ADH is produced from the hypothalamus, but it is secreted from the pituitary gland. Here, this is the pituitary gland. So if they ask you which one secretes the ADH, it's pituitary gland. And one more thing I want you to know about the ADH is that when it is secreted, there is something else that's going to be secreted with it. So it's neurophysin 2. And as far as I remember, we had a question about neurophysin 2. Just for example, having a scenario about the production of ADH and increase in the production of ADH. Which of the following is a marker of increased ADH? The answer would be neurophysin 2. تمام. Antidiuretic hormone. So we knew that it is synthesized in the hypothalamus from the supraoptic and paraventricular nuclei. Just try to know the names. It has two main effects. The first effect is on V1 receptors and V2. So just to know more about ADH, we want ADH to increase the volume of the blood. So there are two main things that are gonna result in the increase in the production of ADH. The first thing is hypovolemia, when we have a decrease in the volume. So there will be an increase in production of ADH to drag more water and to increase the volume of the blood. This is one thing. Second thing, which is the most important thing, is the plasma osmolality. Whenever we have an increase in the osmolality, this indicates that the serum is more concentrated because of less fluid. So these nuclei are going to respond by increasing the production of ADH. Now, ADH goes to V1 receptors and V2. The effect V1 are found in the smooth muscles, which is going to cause vasoconstriction to increase the blood pressure. V2, it's going to increase the recruitment of aquaporins to increase the absorption of water. And this would increase the water and the volume of the blood, which would decrease the serum osmolality. Are we good? So the question is, in nephrogenic diabetes insipidus, we would expect the ADH not to respond to the ADH receptors, right? Yeah, true. So let's say that this question is asking about nephrogenic diabetes insipidus. Here, when we say that after administration of ADH analog, here there will be no response at all. Clear? Because the problem is with the receptors of ADH. So this is the way why we knew that it is not nephrogenic, it is central diabetes insipidus. Because in nephrogenic diabetes insipidus, the problem is with the receptors of ADH. Even if we give ADH from outside, it's not going to work. So this is the reason. Clear? So this is about ADH. Here we kinda talked about what's happening in central diabetes insipidus and nephrogenic diabetes insipidus. Primary polydipsia is not that high yield, and I don't think that they would bring questions about it. But just for you to know, in primary, these three things have kind of similar symptoms, which they are polydipsia and polyuria. However, the serum osmolality of primary polydipsia is way higher. This is, the serum osmolality of primary polydipsia is way lower. So this is the way how to differentiate primary polydipsia than from central diabetes and from nephrogenic diabetes insipidus, by just looking at the serum osmolality. In primary polydipsia is going to be low. Now, we're concerned about central and nephrogenic diabetes insipidus, and I kind of talked about them here in this question. Now, just to talk about the syndrome of inappropriate ADH secretion. So what do you have to know from this is that we have an increase in the ADH production from whatever cause. This could be the causes. I don't think that you have to memorize them by your heart, but just know that it could be as an ectopic secretion from a lung cancer, or for example, a head trauma. Just kind of read them, because you won't be able to know them and memorize them all. Increasing ADH in the blood, which increasing basically the volume of the blood, we would expect a decrease in the osmolality and the kind of these effects. And it could cause also hyponatremia, because we have more fluid, decreasing osmolality and causing hyponatremia. So this is basically in syndrome SIADH. Now, is the concept clear for all of you guys? Yeah. We've got one yes, second yes. Okay, alhamdulillah, it's clear now. And again, sorry guys if the questions, they sound a bit hard, but I'm bringing them up because just for you to know how to approach a question. So it's 5:46. Do you guys want to take 5 minutes break just for a Maghrib prayer, and then we can come back and continue? So yeah, okay, guys. So let's just go pray for 5 minutes, and we come back. Okay, please don't be late so that we can finish at the earliest for you guys just to go and continue studying. Tamam? Okay. So let's go ahead. G. Yeah, true. The answer is G. So a breast pump kit includes a device to record the baby's cry, which is then played back when the mother pumps breast milk for storage and later use. Production and release of which of the following maternal hormone is triggered by the baby's sound and induces the milk letdown reflux? It is G, it's oxytocin. Now let's just go ahead and talk about oxytocin a bit. So oxytocin was mentioned briefly in the lecture. However, it could be an important concept. So you guys just know the stimulatory factors. For example, anything related to the baby, either suckling of the nipple, sound, smell, whatever, everything can cause, like even the smell can cause increase in production of oxytocin. Also dilation of the cervix. So as well as orgasm. So now let's talk about the effects of oxytocin. So whenever oxytocin is increased, it does mainly two main things. The first thing is that it goes all the way and stimulates milk ejection. Okay, so it stimulates milk ejection, not milk production. Just know this difference. So it causes what is called the milk letdown reflex. This is because of oxytocin. Another effect of oxytocin could be, as you can see here, dilation of the cervix. It could result in stimulation of the uterine muscles, which would cause them to contract, resulting in like propelling the delivery of the baby. So these are the two main effects. I think it's straightforward and clear. So let's move on to the second question. So guys, just one thing before you read the question. The questions that are like increase, decrease, normal, increase, decrease, normal are kind of important because we had a couple of them in our exam. So we had a clinical scenario and there's a table, increase, decrease, and normal, and we have to choose an answer. So try to familiarize yourself a bit with them. So yeah, go ahead and read the question. B. تمام. Okay. Anyone wants to volunteer and answer the question? Or shall I go ahead and just answer it? Okay, I'll go ahead and answer it. So, yeah. A previously healthy 35-year-old woman comes to the physician because of palpitations, 1, anxiety, 2, weight loss, 3, pulse is high, 4, fine resting tremor, 5, patellar reflexes are increased. We have pregnancy is negative. Okay, so now we have these 5 symptoms. We have palpitation, anxiety, weight loss, and it's more likely it's going to be there are a couple of effects that could result in the same in kind of these things, but however, we're more towards the thyroid now. And the question is asking you which of the following thyroid laboratory values could be expected in such a case. So the way I want you to approach the increase and decrease questions is that you don't have to like start from the first column, not necessarily at all. So when you saw this question, you know that these are the symptoms of hyperthyroidism. So by default, what are the things that are going to be increased? 100% are going to be increased. Hyperthyroidism, increase in the thyroid hormones. So you go and follow what are the thyroid hormones? We can see this column and this column. So both of them should be elevated. And actually, the only answer that has both of them elevated is B, regardless of the situation of TSH and TBG. Clear? So now we have like a 78% chance that the answer is B. Now we move on. We move on and see. So this is basically a case of hyperthyroidism. Whenever we have an increase in thyroid hormones, as a reflex, there will be a decrease in the TSH levels because of the feedback inhibition mechanism. I mean, so it would be decreased. Now, some of you might say, okay, so there could be a thyroid, there could be pituitary adenoma resulting in increase in the TSH production, which is causing an increase in the thyroid hormones. That's completely true, 100% true. So increase in TSH and increase in thyroid hormones could also be expected. However, we don't have this answer here in the choices. So this would be, so this is the reason why would answer be the correct answer. Now, TBG, like we have certain factors that could result in an increase or decrease in the levels of TBG. One of them is pregnancy. They said pregnancy is negative. So we wouldn't expect to have an effect on TBG that much, which would be normal. So this would like lead us more towards the answer is B. So I think you all agree that why the answer is B, and you all know why the answer is B. Now let's just go a bit about the physiology of thyroid hormones. So it all starts from the iodine levels that are circulating in the blood. So whenever we have sufficient iodine will enter into the cell by the symporter or the co-transporter, sodium iodine. It enters. Then after entering here, it goes all the way into the follicular lumen. There are three things that are going to happen: oxidation, organification, and coupling. All of these three are happening because of the enzyme thyroid peroxidase. So oxidation, it will be oxidized, and then organification, it will be added to the thyroglobulin, which would result in the production of monoiodothyronin and diiodothyronin. So MIT and DIT. This is organification. Coupling is basically adding this MIT, mono, and DIT, di, into each other. So mono and di, when we add them together, would result in the formation of T3. Di and di, when we add them together, would result in the formation of T4. So that's why we have T3 and T4 in thyroglobulin. Then there will be endocytosis, and then by the effect of proteases, it will result in the degradation and the removal of T3 and T4 from thyroglobulin, which would result in the production of T3 and T4. Thyroglobulin will re-enter the cycle again, and it could be reused again. Now, you should know that T4 is way more, the levels of T4 way more than the levels of T3 in the blood. However, in the peripheral tissues, T4 is going to be converted to T3 mainly by the enzyme 5-deiodinase. So this is the basic physiology here. And we should know that thyroid hormones have a negative feedback mechanism on anterior pituitary and the hypothalamus. Great. So this is about the thyroid. Regarding the functions of the thyroid, you kind of have to memorize them as the 7 Bs. Why I'm telling you to memorize the effects, because by memorizing the function and the effects, you will be able to know what's going to happen as a result of hyper or hypothyroidism. So it increases brain maturation, bone growth, and etc. So let's move on to talk about the so this is the other question. Okay, I have the completion of hyper and hypothyroidism in later questions, but just going over the function. Here we have brain maturation, bone growth, beta adrenergic effects. It increases beta-1 receptors in the heart, which is the reason that causes increased cardiac output, heart rate, which would contribute to an elevated pulse as well as palpitations. It increases basic metabolic rate because hyperthyroidism leads to increase in metabolism, which would result in increase in ATP production. ATP is needed for sodium potassium ATPase, so there will be an increase in this function. And as a result of the increase of this ATPase, there will be, for example, increase in body temperature, which would result in heat. There might be some increase in sweating as well. So this could be because of this receptor. Also, when we have an increase in the metabolism, there will be an increase in weight loss and more weight loss. So, okay, and blood sugar, it increases blood sugar and it increases the levels of the lipid in the blood. Now, we have a question here. Why wouldn't the answer be C? Okay, so I understand that the answer is C is basically increase in free T4, free T3 is normal, TBG is elevated, and TSH is decreased. So now, based on this answer, let's just dissect why wouldn't it be C. Now, hyperthyroidism would have an elevated levels of T4 and T3 in the blood because, as we saw here, there will be an elevated levels because of increase in thyroid hormone production. Thyroid hormones are going to be produced as T3 and T4. Now, we all agree that T4 is going to be produced way more than T3, way more than T3. However, T3 is still produced and it's still going to be elevated in case of hyperthyroidism. Even if it's a small elevation, it will still be elevated. So this is the first explanation. Second thing is that here it says that there will be an elevation of or increase in TBG. Now, from what is mentioned in the slides and from what's known is that TBG, thyroxine binding globulin, is increased because of certain factors, and mainly and the most high yield are two. The first one is pregnancy, and the second one is the use of oral contraceptives, which is mainly overall increase in estrogen levels. Increase in estrogen levels have an effect on the liver, which would result in increase in the production of thyroxine binding globulin. So here they said that urine pregnancy test is negative. So we don't have pregnancy. And we're not sure about if the female patient is taking OCPs or not, but all the things that are in the scenario, they're not leading us towards an elevation of thyroxine binding globulin. Is it clear? Why wouldn't it be C? So regarding pregnancy and thyroid, pregnancy increases TSH receptors as well as TBG production. So in terms of the first part, pregnancy increases TSH receptors. I'm not actually quite familiar with this information. However, I'm gonna check it out and I think I can get back to you, but let it towards the end, okay? But for the second information, if it increases TBG production, this is 100% information. So whenever we have pregnancy or oral contraceptives, we can expect that thyroxine binding globulin is going to be increased. Okay. So this is happening in pregnancy and OCPs. But if it increases TSH receptors, I'm not quite sure. I'll have to double check it. Tamam, Jenna? Why is there shortened relaxation phase? Tamam. So the shortened relaxation phase is basically because in hyperthyroidism, it has some of the neurological effects. So of its neurological effects is basically the increase in the contraction of the muscles, and the response of the reflexes of the joints is going to be increased. So because of the hyperthyroidism and increase in the contraction of the muscles, increase in the reflexes, this would result in a more contraction, more increase, which would result in a decrease in the relaxation phase. So this is kind of a simple explanation of why in hyperthyroidism patient, there will be a shortened relaxation phase. Like you don't have to know deep details about why would it happen, but this is just in general. Is it clear? The ECG that increases TSH receptors. Okay, so I'll have to check this information actually. I can't say anything about it. I'll have to check it and get back to you, Jenna. But let it towards the end. Tamam? Just remind me towards the end. So is everything clear about this question? To all of you? And why is the answer is B? تمام. Okay. Let's move on now. This question. Let's go. Just guys, focus on the wording of the question. We've got a couple of A's. Okay. Anyone has any other answer? Okay, alhamdulillah. It looks like I'm a good teacher, alhamdulillah. Okay, so the answer is, yeah, correct. It's A. So as we mentioned like a couple of minutes ago, here we have a pregnant lady. And today she's feeling well, no history of serious illness, pulse, it's okay, blood pressure, examination shows no abnormalities. Okay. So from this scenario, the only thing that we need to know is the patient is pregnant. That's it, period. So what is the effect of pregnancy on the levels of thyroid hormones and these stuff? So as we said, in pregnancy, there will be an increase in estrogen. And because of this increase, there will be an effect on this will result in an effect on the liver, which would result in an increase in the thyroid binding globulin production. Are we clear so far? Now, increase in thyroid binding globulin, it takes the free T3 and free T4, bind to them, resulting in an increase in total T3 and T4. So total T3 and total T4 are basically the free T3, T4, which they are bound to the thyroid binding globulin. That's when we say this is total T3, this is total T4. So whenever we have an increase in TBG, which is thyroid binding globulin, and increase in the binding of T3 and T4 to this TBG, there will be an increase in T3 and T4. So by now we know that increased TBG, increased T3, T4. Now, why it is normal and normal, I'm gonna come to this, but if you look at the answers, increase. None of the answers have increase, decrease. So now you're kind of quite sure that it is A. But to make sure more and to be confident, why T3 and T4, free T3 and T4 are normal? So does anyone want to unmute and tell me why, or should I go ahead and just say it? Okay. Okay, I'm gonna go ahead and just say it. So just focus with me now. We have free T3, T4, we have TBG. They're gonna be bound, clear? So technically there will be a decrease in T3, free T3 and T4 levels. Are we clear so far? But this decrease will like kind of do a compensation. Because of this decrease, there will be an increase in TRH and increase in TSH, and then increase in thyroid hormones production. So there will be an immediate compensation for this. They're not gonna stay like decreased. Are we clear? Why the T3 and T4 hormones levels are normal? They're not decreased. So it's because of the compensation. Because like I remember even me myself, I thought why would T3 and T4 be normal if they're going to be bound to TBG? But because of the compensation, there would be normalization of their levels. Okay, alhamdulillah. So it seems like it's clear. So let's move on to the yeah, here. I think this is in your slides as well. So TBG will be increase in pregnancy and oral contraceptives use. It will be decrease in steroid use and nephrotic syndrome. Clear? I don't think that anyone would ask you about decrease in TBG, but most likely they're going to be asking you more about increase in TBG. Just know this concept. So this is a question. It's a long question, but it's an easy one. And I'm gonna get back to your question. Just let us finish this question and we can discuss it. It's fine. Mm-hmm. I've got a couple of B's. Okay. So the answer is yeah, correct. It's B. Now I want someone just to unmute and just tell me what is the like the the key sentence that told you that it is B, not something else.
Is it due to bulging of the eyes?
Mm-hmm.
And it's already hyperthyroidism.
Mm-hmm.
Yeah, because of what do you call it? Like weight loss. There's also high blood pressure, high pulse pressure.
Mm-hmm.
And there's also the main characteristic feature of Graves' disease is that there's a proctosis of the eyes, or yeah, proctosis of the eye.
Mm-hmm. Okay.
So that's
So thank you,
non-type.
Anam. Yeah, it's 100% correct. So it's mainly because of the prominence of the globes of the eyes, which is bulging of the eyes. So this is basically a hallmark feature of Graves' disease. And from this scenario, we can know that the symptoms that are presented in this scenario, they're kind of similar to the ones that were in the previous scenario, which is the hyperthyroidism symptoms. But the only key feature that told us that it is the Graves' disease is the prominence of the globes of the eyes. Now, why it's not the rest of the answers? From the answers, we can A, C, and E are symptoms of are causes of hypothyroidism. However, Hashimoto's, I'm not sure if any of you saw it, but it could result in a kind of hyperthyroidism and then prolonged duration of hypothyroidism. But don't complicate yourself, it's hypothyroidism, okay? Now, why it's not D? The first reason is because of the prominence of the globes of the eyes. The second reason is because here we said that the thyroid gland is diffusely enlarged, so it's all enlarged. That's basically goiter. And thyroid adenoma, it's when we have like nodules that are going to be enlarged in the thyroid gland. So you won't expect a diffuse enlargement. But the most important feature is the prominence of the globes of the eyes, which is the reason why it's Graves. Clear? So before explaining this question, I'm just gonna go back here and explain a point that, okay, someone asked, what is total T3 and T4? Yeah, so when I said total T3 and T4, it's correct. It's not only the one that is bound to the thyroid binding globulin, total, it's measuring everything. So it's measuring the free floating, free T3, T4, plus the one that are bound. But why I said it's gonna be elevated, because the ones that are going to be bound to TBG are going to be like way more than the ones that are going to be free in the blood, which is causing the increase in T3, in total T3 and T4. Is it clear enough? Yeah, and by the way, thank you for pointing this out. So let's go back to our question. It's Graves' disease. Okay, so now I want you to answer these with me. So it's Graves' disease, and we know it's hyperthyroidism. TSH is increased, decreased, or normal? Quickly. Low, low, low. Decrease. Okay, so it's decrease. Free T4 is decrease, increase, normal. Total. True. LDL. That's the trickiest. Okay. So just let me explain this quickly. It's fine if you guys didn't get this, because it was not like mentioned that much in the slides, but it is gonna be decreased. Why? I'm just gonna let you know why now. I didn't put it because I'm not sure if they could ask you about it, but just make sure to know it, and just get familiarized with it, because it can help you in the when answering the question. So it's a big slide. Let's just digest it quickly. Now I'm just gonna tell you about the differences in hypo and hyperthyroidism. The ones that you can actually understand why, I'm gonna try to explain them. So here in hyperthyroidism, I said that there will be an increase in ATP, increase in this receptor's activity. So there will be an increase in the basic metabolic rate, which would result in increase, like in more weight loss. It would result in heat. It would result in sweating. And the opposite, because of it decreases in hypo, it would result decreased sweating, cold, and more of a weight gain. Clear? Here, regarding also one more thing, is the ophthalmologic effect. In hypothyroidism, it could result in periorbital edema. You guys should know this. However, in hyperthyroidism, it's going to result in two main things. The one that is only specific for Graves, which is the exophthalmos, bulging of the eyes, and the one that could be seen in the rest of the hyperthyroidism diseases. So lead retraction, okay? So lead lag and lead retraction, they are not specific for Graves. However, they are symptoms of hyperthyroidism, because they are happening because of increase in sympathetic stimulation, not the same cause as Graves. So that's why they can be seen in other hyperthyroidism. In gastrointestinal, there will be an increase in diarrhea. Why? Because like everything is kind of increased now. This would result in increase in the motility in the lining of the epithelium, and this would result basically more of contractions and diarrhea. However, in hypothyroidism, they will be less functioning, and this could result in constipation. What else from here? Both have reproductive effects, so don't be like kind of confused about this. For the neuropsychiatric is important to differentiate between both. So in hyperthyroidism, there will be hyperactivity, more activity, more contractions, tremors, and this would result in increase in the reflexes as well. And this is why there will be shortness of the relaxation time. Clear? For the one that asked about shortness of the relaxation time. For hypothyroidism, everything is going to be suppressed, hypoactivity, fatigue, weakness, depressed mode. This is basically what's happening in hypothyroidism. For cardiovascular, if you remember when we said the function of thyroid hormone is the 7 Bs, one of the 7 Bs was increase in the B1 receptors in the heart, which would result in tachycardia. The opposite thing happened in hypothyroidism, which is bradycardia. Now here in hyperthyroidism, these one we explained them. Now let's go to this LDL. Now, because in hyperthyroidism, there will be more recruitment of LDL receptors, which will, like more LDL receptors means that they are taking more LDL from the blood. That's why LDL levels are going to be decreased. And the opposite is happening in hypothyroidism. Tamam? That's the main reason. Just know this information. It might help you when answering some of the questions. And one more important point I need you guys to know is the reason behind the exophthalmos and bulging of the eyes. It's basically because in Graves' disease, we know that the mechanism behind it is the TSI, thyroid stimulating immunoglobulin. Because of TSI, because of the TSI, there will be TSI goes and binds to the fibroblasts, which would result in cytokine release, TNF alpha and interferon gamma. And these would result in increased fibroblast proliferation. And the most important sentence is the production of hyaluronic acid and GAGs or glycosaminoglycans. So because of the increase in production of these two, there will be the bulging of the eyes. And this is basically a hallmark feature of Graves' disease. I hope it's clear. Now, someone asked, why is there low LDL again? So why would LDL receptors be increased? Now, why is the reason of increased LDL receptors? I'm actually not quite sure about this. I can search it up and get back to you. It's fine, but just remind me towards the end so that I can Google it. But from what I know, it's basically there will be an increase in the LDL receptors recruitment in hyperthyroidism. Due to this increase in LDL receptors recruitment, more LDL is going to be taken from the blood, which would result in a decrease in LDL levels. Is that clear? Why is there low LDL? Yeah, okay, it's clear. Yeah, like if what I'm expecting is it's basically because of the increase in the metabolism, but maybe there's a specific cause. I can search it up and get back to you if there's any specific cause. But I would say like just as a general idea, it could be because of the increase in metabolism. So let's move on. Is everything clear about thyroid? Yeah. The rest, okay. No. Let's move on. Ta-da. Okay. So we've got a couple of D, and D. Okay. So this is a case of basically here we have a constipation, fatigue, weight gain, pulse is low, dry skin, cool skin, pallor, periorbital edema. These are all leading us towards the symptoms of hypothyroidism. As I told you, in hypothyroidism, we're expecting the thyroid hormones to be decreased, so decrease. We're expecting TSH to be increased, okay? And we're expecting less LDL receptors. Less LDL receptors means less uptake of LDL from the serum, which would result in more LDL that's there and increase in LDL levels. Are we clear? Yes. Okay. So just talking about the symptoms of the causes of hypothyroidism, two of the most important causes are Hashimoto's disease. I'm just going to tell you about a few of the things that can lead you towards the Hashimoto's disease, to choose Hashimoto's disease in the question. So they could tell you that there is thyroid like an antibodies towards autoimmune antibodies against thyroid peroxidase or against thyroglobulin. This is one thing. Second thing, there might be another autoimmune disease that's happening in the patient. So maybe, for example, type 1 diabetes is the most common that they get it in the questions. So these two basically lead us more towards Hashimoto's disease, like gives us an idea that this could be Hashimoto's. Now, the other thing is basically endemic colloid goiter. Endemic colloid goiter is happening because of a decrease in iodine and in iodine deficiency. And just two important things about iodine deficiency. Where can you see them? You can see them in two main, in quite a few situations, but the two most common ones are in vegan people and people living in mountain regions. So these are the two most important causes of a decrease in iodine or iodine deficiency. Just know them because if you get them in any of the questions. Now let's move on to this question. Let's go ahead. It's fine, guys. Just take your time answering the question. تمام. So let me go ahead and start explaining the question. So a 44-year-old woman is brought to the physician by her friend who is worried because the patient has appeared depressed and questioning fatigue, constipation, and pain in her hands. She has a history of kidney stones, constipation, fatigue, kidney stones. Renal enzymes are normal. X-rays shows thinning of the bones of the phalanges and several well-defined cysts. Bilateral, okay. So which of the following sets of serum parameters is most likely in this patient? So the answer is A, correct. Now, why is the answer is A? Here we have a couple of symptoms that are more towards the hypercalcemia. What are these symptoms? They are fatigue, constipation, kidney stones, history of kidney stones. They are all leading us towards the symptoms of hypercalcemia. Plus, the patient has pain in her hand, and the X-ray shows thinning of the bones. Just forget about the rest. I know the rest might be more than your level, but it's fine. Just forget about it. It's basically thinning of the bones and hand pain. So we have a problem that's happening with the bones. One, we have kidney stones, constipation, fatigue. So now we're more towards hypercalcemia symptoms. Great. So let's just approach it from the way I told you about. So we have increase in calcium levels. So let's just cross out anything that has something else. So increase in calcium. Now we have increase in calcium, and I told you that the patient has hand pain and there is thinning of the bones. So there might be an effect of the bones that is resulting in an increase in the calcium. And whenever we have something that's causing the bones to increase the release of calcium, there will be accompanying increase of alkaline phosphatase or ALP. So it's going to be also elevated. Tamam? So in this way, we kind of knew that it could be A. Clear? Now, of the most common causes of hypercalcemia could be hyperparathyroidism. So in this case, when we're expecting the parathyroid hormone to be elevated. So hyperparathyroidism causing an increase in the bone resorption, which would cause hypercalcemia. And also one of the PTH effects is decrease in phosphorus. That's why it's A. Now I'm gonna go ahead and talk about PTH more, and then we get back to the questions to know why it's exactly A. So let's just start talking about parathyroid hormone. It's produced by the parathyroid gland, specifically chief cells. Know the histology of the chief cells. Now let's talk about I want to talk first about the effects. Okay, so let's just imagine that, we have parathyroid gland, okay? Parathyroid gland produced parathyroid hormone. Now parathyroid the hormone has, it's gonna result in three main effects. Let's talk about the first effect, which is going to be on the kidney. On the kidney, it causes three main effects on the kidney. The first one is that it enhances the production of 1-alpha hydroxylase. Just keep that in mind. Just put it on the side for 1 second. The second thing is that it causes increase in the reabsorption of calcium. Tamam? It causes increase in reabsorption of calcium from the distal convoluted tubules. One more thing is that it causes a decrease in the absorption of phosphate by blocking sodium phosphate cotransporters in the proximal convoluted tubules. Why is this happening? Because usually when we have phosphate and calcium, they're going to bind together. Whenever calcium is bound to phosphate, its levels are going to be decreased in the blood. So we have no effect of PTH. PTH is there to increase blood calcium levels. So that's why it increases blood calcium and increases calcium reabsorption and decreases phosphate reabsorption. So these are the three main effects on the kidney: increased calcium reabsorption, decreased phosphate reabsorption, and increased production of 1-alpha hydroxylase. Now, 1-alpha hydroxylase goes all the way and stimulates the production of vitamin D. Clear? Now, what does vitamin D do? Vitamin D has two main effects. The first effect is on the intestines. It enhances the absorption of both calcium and phosphate. Clear? It also vitamin D has an effect on the bones. So what does it do on the bones? It does two main things on the bones. The first thing is that it enhances bone resorption of the old bone, which is the damaged bone resorption, which would result in increase in calcium and phosphate in the blood. Also, vitamin D is important for bone mineralization. So it does two things. Clear? It causes bone resorption of the old bone and bone mineralization of the new bones. These are the effects of vitamin D. So the overall effect of vitamin D is increased calcium and phosphate in the blood. Now, moving on to talk about the parathyroid, to complete talking about the parathyroid hormone. Parathyroid hormone also acts on the bones. What does it do? It increases bone resorption, which would increase calcium and phosphate levels in the blood. Clear? Now, just focus with me, guys. Now, I know that we said that vitamin D causes increased calcium and phosphate. The effect of PTH and vitamin D on the bone increases calcium and phosphate. So eventually we would expect phosphate levels to increase. However, the most important factor for increase in phosphate is the kidney. Clear? Because we don't have increase in the reabsorption of phosphate from the kidney. That's why the level of phosphate in the blood is going to be decreased. Are we clear? Just for you to know why is this happening. Are you guys with me on the same page? Yes, yes, yes. Here, yes. I just got 2 yes until now. The rest? Talking too much, actually. Okay, so alhamdulillah. So far, we're good. So that's why in symptoms of hyperparathyroidism will result in hypercalcemia, hypophosphatemia, and due to the effect of PTH and vitamin D on the bones, there will be increase in alkaline phosphatase. Going back to our question. Yeah. Increase calcium, decrease phosphate, increase alkaline phosphatase, increase parathyroid hormone. That's it. Now let's talk about some the regulation of the PTH. The parathyroid gland has basically cells. These cells are receptors. These receptors are called the calcium sensing receptors. They are sensing the levels of the calcium in the blood. So whenever we have an increase in the level of the whenever we have an increase in the level of calcium, we don't want more calcium to be there. So these calcium sensing receptors are gonna sense this calcium, which would result in the suppression of PTH, so less PTH is there, and eventually less calcium. So this is basically the main role of the calcium sensing receptors in the parathyroid gland. Now let's talk about the regulation of PTH. Any decrease in the serum calcium levels will result in an increase in PTH because PTH wants to regulate the calcium levels. So this is the first effect. Second one is increase in phosphate levels. Why is this why does it cause increase in PTH? Because of like two main things. The first thing is that the parathyroid gland kind of sense that there is an increase in phosphate. This would result in increase in PTH secretion. The other and an important cause is because I told you that whenever we have increase in phosphate, phosphate binds to calcium, resulting in less calcium in the blood. Clear? Less free calcium. Whenever there is less free calcium, there will be increase in PTH. So that's another cause for you to know why it doesn't cause increase in PTH secretion. Now we come to magnesium. Magnesium is the brother of calcium. How to know this? It's positive 2, so it's the brother of calcium. So if something wrong with magnesium, there will be something wrong with calcium. Just know it like this. However, if it's way decreased, PTH is going to be decreased because magnesium has an effect on PTH and the parathyroid gland. And I remember I tried to Google this and what is the effect? I didn't know exactly, but they just mentioned that whenever there is a severe hypomagnesemia, PTH will be decreased as well. Tamam? So this is about the parathyroid gland. This is about the parathyroid hormone function. And here we come to primary hyperparathyroidism. I told you that symptoms of hypercalcemia include, just try to memorize the mnemonic, stones, thrones, bones, and psychiatric stones, thrones, groans, bones, psychiatric overtones. Just try to memorize it and you'll be able, inshallah, to get any question correct. And we talked about what's going to happen in primary hyperparathyroidism. So now let's move on. I'm just going to explain these later. Yeah, let's move on to this question. Mm-hmm. Mm-hmm. Yalla, the rest of the guys, answer. Okay. So let me just go ahead and explain the what's going on in this question. So the answer is to it's B. Now, what's happening in this question is that we have a patient that has chronic kidney disease. And when they said that serum creatinine concentration is 4.5, and we all know creatinine is one of the markers of kidney function, so it's elevated. This indicates that kidney is there's something wrong with the kidney and there's a kidney disease. So whenever we have a chronic kidney disease, we said that there are three main functions that are happening in the kidney. The first one is the production of 1-alpha hydroxylase. 1-alpha hydroxylase is important for the for vitamin D. So what do we expect vitamin D levels to be whenever we have a decrease in 1-alpha hydroxylase production due to chronic kidney disease? What are the levels of vitamin D? Is it decrease, increase, decrease? We got one. Tamam. So another thing is that I told you kidney is the most important one in terms of the calcium and phosphate. So we don't have the reabsorption effect of calcium. So this would result basically in calcium levels to be decreased. Clear? Clear. So, and the phosphate, because of the same reason, the kidney is not functioning well, which would result in an increase in phosphate. Now, what do we expect the PTH to happen whenever it senses that there is a decrease in calcium and an increase in phosphate? What's going to happen to the PTH? Increasing. Okay, so this is basically a case of secondary hyperparathyroidism. Clear? Secondary hyperparathyroidism is that it happens whenever we have a cause resulting in a decrease of the calcium levels. This would result in a compensatory mechanism by increasing parathyroid hormone production. So this is secondary hyperparathyroidism. And we talked about why the effect of on vitamin D, calcium, and phosphate is this. So let me just go back to hyperparathyroidism here. Yeah, secondary hyperparathyroidism. So secondary hyperparathyroidism, it happens due to a decrease in the calcium reabsorption or increase in the phosphate. Clear? Which would cause a compensatory mechanism increasing the parathyroid hormone. Now, we have two main causes of secondary hyperparathyroidism. We have either chronic kidney disease. The second one is going to be vitamin D deficiency. Clear? So because these are the two most common causes. Now, how to differentiate between both of them? The in vitamin D deficiency, because we said that vitamin D is important for calcium and phosphate absorption from the intestines. So whenever we expect vitamin D deficiency, phosphate levels are going to be also down with the calcium. So hypovitaminosis D causes decrease in calcium as well as a decrease in phosphate. Now, when we go on to talk about chronic kidney disease, when we talk about chronic kidney disease, there will be a decrease in calcium and an increase in phosphate. So this is the differentiate between chronic kidney disease and vitamin D deficiency. I'm going to repeat it again. Chronic kidney disease, we have less calcium, more phosphate. Vitamin D deficiency or hypovitaminosis D, we have less calcium and less phosphate. This is in terms of this question. Let me just talk quickly about here what's going on. Because of vitamin D deficiency, we said that there will be a decrease in calcium levels and phosphate levels. As a compensatory mechanism, there will be an increase in PTH. Clear? Clear. In chronic kidney disease, there will be decrease in calcium, there will be an increase in phosphate, and as a compensatory to increase in phosphate and decrease in calcium, there will be an increase in PTH secretion. Now, hypoparathyroidism, because we have less parathyroid hormone, so we expect calcium to be low. Because of the parathyroid hormone on the kidney, it's not acting on the kidney, it's not decreasing the reabsorption of phosphate, so there will be it's not decreasing the because of decrease in PTH, there will be a decrease in the effect of PTH on the kidney, so its effect on phosphate is not going to be there, which would result in an increase in phosphate levels in the blood. Now, for pseudo hypoparathyroidism, we have PTH. However, this PTH, there's a problem with the PTH receptors. So whenever PTH binds to its receptors, it's not going to result in its effects. So what are the effects that we expect in PTH? We're expecting to have more calcium and less phosphate. Because the receptor is not functioning well, there will be a decrease in the calcium and there will be increase in phosphates. So that's how to digest this table. Are we clear?
Yes, clear, but in this case, how would you differentiate between hypoparathyroidism and the pseudo hypoparathyroidism?
And hypoparathyroidism and pseudo hypoparathyroidism?
Yeah, because they would present with the same lab, like the same levels in serum.
So in hypoparathyroidism, the function is with the parathyroid
Oh,
gland.
yeah, sorry,
So
the PTH. Yeah, the PTH.
while in pseudo hypoparathyroidism, because we don't have the effect of PTH, so there's no something that's regulating the calcium levels in the blood. So calcium will be low. Tamam?
Yeah, clear, yeah.
What's the compensation? What's the compensation if we have low calcium?
Increase PTH.
Yeah, that's why PTH is going to be increased here.
Yeah.
Tamam?
Yeah. I just lost track for a second. Thank you.
Yeah, it's fine. I know, by the way, these are a bit confusing, but just try to understand them. Don't memorize what's increased and what's decreased. Just try to understand. And then when you understand it, you'll be able to know everything else. So yeah, the last question about parathyroid hormone, about parathyroid gland, sorry. Tamam. By the way, this question is not easy, so it's fine if you struggle with it a bit. Okay, I expected. Yeah, I expected. It's a bit confusing. It's fine. Okay, so I'm just gonna go ahead and explain the question. So if you remember, guys, I told you try to know why everything is happening and understand it, then you'll be able to solve everything. So let's just go ahead together and see. Why would the answer is D, correct? Why would the answer be D? Let's start from PTH. Let's rule out C. Why would we rule out C? Now, in PTH-related peptide, there is an exogenous production of PTH, which is basically because of a tumor, resulting in increased production of PTH. Now, because of increasing the production of PTH-related peptide, there will be a decrease in the parathyroid hormone. That's true. However, the levels of calcium and phosphate are not going to be both elevated because there is PTH effect, PTH-related peptide effect. So there will be more calcium, however, less phosphate. So we crossed out C. Now let's talk about magnesium. Whenever we have serum magnesium, let's say we have a decrease in serum magnesium levels. True? Decrease in serum magnesium levels causes an increase in parathyroid hormone. So these we kind of ruled out. This is one of the effects of magnesium. The second effect of magnesium is the severe deficiency of magnesium levels. So whenever we have a severe deficiency of magnesium levels, we're expecting PTH to be low. True? What's going to happen when PTH is low? Calcium is going to be decreased, but phosphate is going to be increased. And in the question, they said they're elevated. The corrected, the plasma calcium and phosphate is elevated. Okay, so now we can rule out B. For albumin, as far as I know, is that albumin binds calcium. Okay, so whenever we have, so let me just explain to you what's happening with albumin. And we have, and I remember I saw this in your slides. So we have acidosis, and in case of acidosis, there will be an increase in the hydrogen levels in the blood. True. So because of the increase in the levels of the hydrogen levels in the blood, hydrogen will be bound to albumin, leaving more calcium in the serum. However, in case of alkalosis, there will be less hydrogen. So albumin will be like kind of free floating. So it's going to go ahead and bound to calcium, resulting in a decrease in calcium and increase in parathyroid hormone. So that's why we kind of can cross out A. This is I tried to simplify the why would we cross out A, B, and C. But the most important thing I want to deliver from this question is that vitamin D can control both calcium and phosphate at the same time. So whenever we have like an increase in the vitamin D, hypervitaminosis D, increase in vitamin D, both calcium and phosphate will be elevated. When we have a severely deficiency in vitamin D, both calcium and phosphate will be decreased. So the only one that controls phosphate and calcium at the same rate could be vitamin D. Is that clear? So this question is just for this information.
So if we decrease the vitamin D, the PTH levels will go back to normal?
If we decrease vitamin D?
Yeah, since...
Yeah. So whenever we have a vitamin D deficiency, we're expecting calcium.
No. So here we have high calcium and high phosphate, right?
Sorry?
So this patient came for hypercalcemia. We have high calcium and high phosphate, right?
Yeah.
And we're expecting the vitamin D to be related to that.
Yeah.
But we also have low PTH. So what would we...
In this question, we have low PTH, صح? تمام.
Yeah.
Okay. So this is a case of increase in levels of vitamin D, because some patients might take a lot of vitamin D supplements, which would cause something called hypervitaminosis D, which is an increase in the levels of vitamin D. Increase in the levels of vitamin D resulting in more of calcium and phosphate absorption at the same time. تمام?
Yeah, I get that part. But what I mean is to fix the low PTH. No, to fix the high calcium, we would decrease vitamin D. But to fix the low PTH, what would we do?
What will we do to fix PTH?
Yeah.
Here, PTH is low because we have high calcium. If we just take out the vitamin D and like the problem that's happening in vitamin D level will be normalized, which would cause calcium to be normalized. Whenever calcium is normalized, PTH will be normalized.
Yeah. Okay. Yeah, that's exactly my question.
You guys don't have to know what do we have to do to normalize the things. You just need to know why would this happen. Tamam? Just don't try to complicate yourself at all. So the only thing I want you to know, calcium and phosphate increase at the same time or decrease at the same time because of vitamin D. This is the thing. Tamam? Just know about this information about this. Parathyroid gland is good. Do we move on to the other lectures? Yeah, okay, let's go ahead. Okay, so this slide is just to, I'm pretty sure that most of you guys ditched this slide and didn't study it because I did the same actually. But just for you to know, I think it's important to know that UV radiation or the sun sun radiation is basically important for vitamin D, and it acts on this from transformation from this part to this part. Tamam? So just know this information because you might get some questions about patients with vitamin D deficiency, and they tell you that the patient is not exposed to sun. So which of the following could be expected? It will be a decrease of the transformation from here to here. We had this question. I actually got it wrong. So I have PTSD from this thing. The second thing is basically the 1-alpha hydroxylase, which I explained. Okay, so let's move on. By the way, this is the most interesting part. I really like the adrenal gland. So go ahead and try to answer the question. They're easy, but you just have to know the concept. تمام. Okay. طيب. Can someone just unmute and tell me why? It will be C. يلا. تمام. Okay, so Tamam, thank you. So the answer is C. Now I'm just gonna go ahead and so there are two main things in this scenario. The first thing is that we knew that there is an XY chromosome, so this indicates that this is a boy, a male. Examination showed infantile female external genitalia. So there's something wrong that's happening here. And serum studies showed a decrease in the levels of 17-hydroxypregnenolone. Tamam. So two main things. This is the first thing. This is the second thing. So this is a scenario of 17 alpha hydroxylase deficiency. Let me just go ahead here and just explain it quickly. Whenever we have a 17 alpha hydroxylase deficiency, we will have a decrease in everything in this area. So what two most important things we have here? The first thing is the cortisol. The second thing is basically the androgens. Tamam. So whenever we have a male that has decrease in androgens, this would result in symptoms which they could be related to female external genitalia, undescended testes, and these kinds of things. Tamam. Now I'm gonna come back to the table that you have it in your slides. Just one second. So whenever we have a deficiency in 17 alpha hydroxylase, we're expecting everything to be shifted to this pathway. So we have a huge increase in everything that is happening here. And as a result of increase in the mineral corticoids levels in the blood, we will expect hypertension and decrease in potassium levels. What also decrease in serum cortisol are happening because this pathway is not here, and female external genitalia is happening because this is not here. Now I'm gonna go ahead here and just go ahead and explain everything that's happening here. Now in 17 alpha hydroxylase, we have an elevated of levels of 17 alpha mineral corticoids. Due to the increase in the mineral corticoids, there will be increased blood pressure. That's basically causing kind of an aldosterone effect, which would decrease basically the potassium in the blood. Now we said that everything in the glucocorticoids and the androgens are going to be decreased, which is the reason that these two are decreased. Androstenedione is decreased. And when we come to XY and XX, you guys should know this by your heart. And I think we had an SAQ about this, like this table. I don't remember the exact syndrome, but in males, because there is less androgens, there will be atypical genitalia, which is female external genitalia, because there is less androgens and undescended testes. In females, there will be lack of secondary sexual development. Now, I tried to Google why would be lack of secondary sexual development. It's related to the decrease in androgen levels, because androgen is also needed for females for the secondary sexual development. That's about 17 alpha hydroxylase. Now, about 21 hydroxylase deficiency. So 21 hydroxylase is basically acting on this level. So it's acting to convert progesterone or 17 hydroxyprogesterone to complete this pathway and this pathway. So whenever we have 21 hydroxylase deficiency, we're expecting aldosterone to be decreased and cortisol to be decreased. So there will be a huge shift towards the androgens. There will be a massive increase in the androgens. Due to the massive increase in the androgens, whenever we have increase in androgens in boys, this would result in symptoms, for example, like an early puberty, precocious puberty. Like, for example, a mother is concerned about his hair boy because like the boy is having, for example, pubic hair, axillary hair, deepening of the voice, and these kinds of things. In terms of females, it's going to result in virilization. We said that androgens are important for secondary sexual development. However, if they're more than the normal limit, they're going to result in virilization. For example, deepening of the voice and increase in the muscularity of the female. Okay, so this is going to happen in 21 alpha hydroxylase, which is basically here. There will be decrease in mineralocorticoids. As a result of decreased mineralocorticoids, blood pressure is going to be low because of the the receptor causes an increase in sodium reabsorption and a decrease in potassium reabsorption. So it causes it causes decrease in potassium reabsorption. So when we don't have mineralocorticoids, less blood pressure, more potassium in the blood. We have low cortisol because of 21 hydroxylase deficiency. We have more of the sex hormones, and these are going to be elevated. High renin because mineralocorticoids are low. Clear? And as we said here, we have precocious puberty. In males and females, we have virilization. Now, in 11-beta hydroxylase, it's kind of similar in terms of the sex hormones and androgens and everything here. However, one thing I want you to know is when we have 11-beta hydroxylase deficiency, we have an increase in 11-deoxycorticosterone. 11-deoxycorticosterone has an effect similar to aldosterone. Okay, so we will have the mineralocorticoids effect. However, it's not from aldosterone, it's from the deoxycorticosterone. So here we have elevated deoxycorticosterone, which is causing an elevated blood pressure and decrease in potassium. I told you they have a similar effect. However, blood aldosterone levels are going to be low. Renin levels are going to be decreased as well. Clear? Clear. So, and cortisol is decreased because here it's basically blocking the pathway of cortisol. And that's it about everything about congenital adrenal hyperplasia. So let's move on to so going back to our question, we kind of explained the question. So let's move on to the second question. Now I want any of you guys to unmute and answer this question. It's straightforward and easy question. I'm sorry, I took too much time, but it's fine. You guys, look at here. We have A. The rest of the guys, all of you agree it's A? Tamam. Okay, so it's a straightforward. Here we have 21 beta hydroxylase deficiency. Let's just move on to the in the scenario. We have examination shows greasy facial skin and cystic acne on the forehead and the back, and the patient is a boy. Exactly, Jana. It's precocious puberty. So these are the symptoms of precocious puberty. Tamam. There is of course axillary and pubic hair as well. So, and here so whenever we have precocious puberty, we said that it could be either 11 beta hydroxylase or 21 beta hydroxylase. However, here we said that the oxycorticosterone is decreased and cortisol is decreased at the same time. So that's why it indicates that it is 21 beta hydroxylase deficiency. It's not 11 beta hydroxylase. Tamam? I think it's straightforward. So let's move on to the second question. Yalla, go ahead. MashaAllah. Okay. If I tell you the answer, if the answer is C, why wouldn't you choose C? Okay. So exactly. So let's talk about the symptoms here. We have history of fatigue, irregular menstrual cycles, recurrent infections, hirsutism, hypopigmented striations, hypernatremia, hypokalemia, metabolic acidosis, okay, midnight salivary cortisol. Sometimes in some of the scenarios, there might be some few things that you can't understand. Why are they there and what do they indicate? but there would be there would definitely be something that's leading you toward the answer, so it's fine. Tamam. So midnight salivary cortisol concentration at 24, okay, they are increased. So this indicates that we have an increase in cortisol, which indicates Cushing's syndrome. Serum ACTH is also elevated. So now we know that the cause of the Cushing's syndrome, increase in cortisol, is related to the ACTH. Tamam. High dexamethasone does not suppress serum cortisol. That's the most important clue in this question. So we know that from this question, we know that there is Cushing's syndrome, there is increase in cortisol, there is increase in ACTH. So there are two most important causes, diseases that could result in this finding, which is the increase in ACTH and increase in cortisol. They are one, pituitary adenoma, resulting in increase in production of ACTH. Second thing, and whenever we have a cancer, resulting in the production of ACTH. How to differentiate between the two? By using high dexamethasone suppression test. So pituitary gland, it responds to the dexamethasone by suppressing the production of ACTH. So whenever we have a high dose dexamethasone, we're expecting it to suppress the production of ACTH no matter what's happening. If it's high, if there is tumor, if it's adenoma, if it's not adenoma, if it's normal, it would be suppressed. Here, it did not suppress, so 100% there's something else that is resulting in an increase in ACTH production, which is causing the symptoms, which is ectopic ACTH production. Now, talking about cortisol, you guys kind of have to know like the function of cortisol. It increases appetite, it increases blood pressure by two important mechanisms. The first one is that it has a similar to mineralocorticoid effect. It binds to the receptors. The second one is that it upregulates alpha-1 receptors, which would result in increasing norepinephrine, epinephrine, and increasing blood pressure. And it could result in increased insulin resistance, diabetogenic, gluconeogenesis. So let's try to know the function and the effect as well. So increase in these would result in hypertension. Tamam. Increase in appetite makes you eat more, weight gain. Insulin resistant and increasing gluconeogenesis would result in basically hyperglycemia. Tamam. Increase in lipolysis means more triglycerides in the blood, which should result in hyperlipidemia. Decrease in fibroblast activity, which decrease in collagen synthesis and these kinds of things, would result in poor wound healing. And because it decreases collagen, so abdominal striae is going to happen. Tamam. It suppresses the immunity. This would result basically in recurrent infections. As we saw in the question, there was recurrent infections. Decrease in bone formation, resulting in an increase in fractures, risk of fractures. Now, Cushing syndrome is basically increase in cortisol levels. We have two main things, ACTH dependent, independent. Independent, which means that something caused increase in cortisol, and cortisol causes feedback inhibition on ACTH. So whenever we have increase in cortisol, it could result in feedback inhibition, which would decrease in ACTH. By measuring and finding that we have decrease in ACTH and high cortisol, we know that it is ACTH independent. And there are two main causes. The first one is that when we give, the most common is when we give exogenous cortisol, we give exogenous cortisol, for example, or as a medication. It will cause high cortisol, less ACTH. The second important example is primary adrenal adenoma, when we have a tumor or adenoma of the adrenal gland, which is producing cortisol, doing feedback inhibition, decreasing ACTH. When we're talking about ACTH dependent, we're talking about two most important causes, which I explained them. Now, here we have the moon facies. I kind of explained some of them. I want you guys to go over them and try to correlate. And an important thing that it's like a tip or an advice. Whenever we have hyperpigmentation, what does it tell you? What are we expecting ACTH whenever we have hyperpigmentation? Is it increased or decreased? High. Tamam. So you guys said it. So if we have symptoms of Cushing syndrome and we notice hyperpigmentation, we can from this information, we can know that this is most likely related to increase in ACTH. Tamam. Another clue, this is the first clue. Another clue is that ACTH, it stimulates the adrenal gland. The most important effect of ACTH, increase in cortisol. Am I right? But it has a small effect on androgen levels. Tamam? So because of this effect on androgen level, we're expecting androgen levels to be increased, تمام? Which would result in symptoms of androgen excess. So acne, hirsutism, and hyperpigmentation can give you an idea that this might be an STH dependent. تمام? Like this is just a tip. I saw it somewhere else. High STH, exactly. Why is the cause? Because of the high melanocyte stimulating hormone. Now, talking about the dexamethasone suppression test, there are two things. We have low dexamethasone and we have high. Now, just to know the difference between them, if we have a normal pituitary gland, if we give low dexamethasone, it will be suppressed. تمام? So, let's say that a normal person with normal pituitary gland, we give low dexamethasone, cortisol levels will be decreased. تمام? Now, when we give someone low dexamethasone and cortisol is still high, this means that we have a hypercortisolism. We have Cushing's syndrome. We have high cortisol. We don't know the cause, but this indicates that we have high cortisol. To know, and then after doing this, we measure ACTH. When we see ACTH is high, now we want to do a high dexamethasone suppression test to know if it's either the pituitary gland or the something ectopic. We did high dexamethasone, it is suppressed. This means that it is Cushing's disease, which is basically the one that's happening in the pituitary, resulting in increase in production of ACTH. If it's not decreased and cortisol is still high, despite giving high dose dexamethasone, it's 100% ectopic ACTH secretion. Tamam? So this is the most common, like it's the area of where they ask more questions. Tamam? Another way is basically CRH stimulation test. I didn't see a lot of questions about it, and I'm not sure if it's as high yield, but just for you to know, if we have an adenoma, pituitary adenoma, resulting in increase in ACTH, when we give CRH, corticotropin releasing hormone, and stimulating this pituitary adenoma, what do we expect the ACTH to increase or what to decrease? To increase, tamam? So increase, exactly. So yeah, I'm gonna repeat this again. So CRH stimulation test is basically we are stimulating the production of CRH. So we are kind of increasing CRH, tamam? So by increasing CRH, we are expecting ACTH to be increased, tamam? Tamam. So whenever we have a pituitary adenoma, because of like more stimulation of CRH, there will be even more production of ACTH. So this indicates that it is a pituitary adenoma that is causing Cushing's disease. Tamam? But like most of the time, they talk about high dose dexamethasone. Is the concept clear about the adrenal gland? Okay, tamam, alhamdulillah. So let's move on. Question 17, a certain endocrine disorder can lead to an elevated blood pressure, decreased potassium levels, sodium and water retention, and decreased renin activity. Which of the following is the most likely diagnosis? Yalla, go ahead and answer. We have two Ds. Like, the answer is D. But can you tell me what is the thing that led you to choose D? Okay, I understand A, B, and C are not related, but why not E? Renin is decreased. Tamam. You guys answered the question correctly. So hyperaldosteronism is an important concept that you have to know, and you have to differentiate between primary and secondary based on the options that you have. So you guys said that in primary hyperaldosteronism, we have a tumor that's producing aldosterone, causing aldosterone effect. What are the effects of aldosterone? Sodium water retention, decreased potassium, and elevated blood. This will lead to elevated blood pressure. Tamam? But This would cause a negative feedback on renin, which would decrease renin. So whenever we have high aldosterone, low renin, this is primary hyperaldosteronism. Tamam? When we have a secondary hyperaldosteronism, what's happening in this case is that like it's a secondary hyperaldosteronism. So the hyperaldosteronism, high aldosterone, is secondary to something that's happening. So there is something that's causing high aldosterone. For example, we have a hypovolemia causing increased renin, increased aldosterone. So in secondary hyperaldosteronism, we're expecting high renin and high aldosterone at the same time. Tamam? Tamam. One more important concept about the hyperaldosteronism, primary and secondary, is to know, for example, there is a question. Let me just give you a question. So we have a patient presenting to the clinic because of the primary hyperaldosteronism. So the answers could be elevated blood pressure, decreased potassium, increased sodium, and increased renin. So what would we choose? It's confusing. I'm going to repeat it again. A patient that has primary hyperaldosteronism, what do we expect to find in the lab when we do the lab test? High blood pressure, low potassium, high sodium, high renin. I'm going to repeat it one last time. Patient with primary hyperaldosteronism, we measured the lab. We did lab, and lab showed one of the following: high blood pressure. Okay. Yeah, it's low. I think I messed up the answers. So just forget about the question. The message I want to deliver is that whenever you have a patient with a primary hyperaldosteronism, we're expecting renin to be decreased. Tamam? We're expecting blood pressure to be increased, and we're expecting potassium levels to be decreased. However, if you see an answer that is high sodium levels in the serum, that's not the correct answer. It increases sodium reabsorption, but it doesn't cause high sodium levels in the blood. Tamam? Do you guys know this information? Because that's important information. Because of water, like there are a couple of mechanisms. For example, the first thing is that because of it enhances sodium and water retention. So water kind of dilutes sodium is one of the things. It remains the same concentration. And another thing is that because of hyperaldosteronism increases aldosterone levels, increasing sodium and water. Whenever we have an increase in the water, there will be increase in production of a hormone called atrial natriuretic peptide. You guys don't have to know this information that much. And this would decrease sodium reabsorption, which would allow sodium to stay the same. Tamam? This is called the sodium escape mechanism. But for now, for this, like for the level of this exam, just know that it's because of sodium and water, and they are normalizing each other. So whenever we see primary hyperaldosteronism, high sodium is not a correct answer. Tamam? Are we on the same page? Do I move on? Okay. So now I'm gonna move on. So here's just secretion of aldosterone. I brought this from your slides, so guys, you can like just go back to the slides, or if you just want to read it from here, you can just read it. It's not much explanation. Primary hyperaldosteronism, secondary hyperaldosteronism. We kind of explained both of them, and aldosterone and renin. So we come to adrenal insufficiency. Tamam. So primary adrenal insufficiency, from its name, primary adrenal insufficiency, there is a problem with the adrenal gland itself that is resulting in adrenal gland to be insufficient. So there will be less cortisol. However, the other hormones are going to be decreased as well, because the adrenal gland, like all of the adrenal gland is damaged. Tamam? So that's why all of the other hormones are going to kind of be decreased. Now, what would be the symptoms? Whenever we have low cortisol, ACTH will be increased. Tamam? What's going to happen to MSH? Is it going to be increased as well or decreased? Whenever we have high ACTH production, increase. So there will be increased MSH. So we are expecting hyperpigmentation and adrenal insufficiency. Tamam? That's why there is hyperpigmentation. This is one thing. The second thing, I told you that all of the adrenal gland is affected. So there is less mineral corticoids. Less mineral corticoids causes hypotension. Tamam. Also, what's going to happen to potassium? It's going to be increased because there is less effect of aldosterone. So hyperkalemia could be seen as well. Tamam. This is the thing that you need to know about primary adrenal insufficiency. Patients are presenting with hypotension and hyperpigmentation. They're gonna like bring a big scenario, but whenever you see like adrenal gland is destroyed, damaged, and you see hyperpigmentation, hypotension, خلاص, inshallah you know that it is primary adrenal insufficiency. Now let's move on to talk about secondary adrenal insufficiency. Secondary adrenal insufficiency is happening secondary to the decrease in the ACTH. So decrease in ACTH in the pituitary is causing the decrease in cortisol only. So whenever we have decrease in ACTH, will there be hyperpigmentation or no? No, tamam. And whenever we have a decrease in ACTH, it's kind of only affecting the glucocorticoids. So it's going to result in the mineralocorticoids part is not going to be affected. So aldosterone is normally being produced and it's preserved. Tamam? Now, glucocorticoids, they have effects on androgens, but it's a minimal effect. Tamam? But in secondary adrenal insufficiency, the only thing we need to know is to differentiate it from primary. How to differentiate it? There is no hyperpigmentation and blood pressure is normal. There's no hyperkalemia. Aldosterone is normally functioning. Tamam? Just I saw the doctor talked about this syndrome. This syndrome, until now, I don't know how to pronounce it. Just know it's Waterhouse something. Waterhouse something syndrome is basically happening due to a bacteria called Neisseria meningitidis. Like what does it do? It causes adrenal insufficiency. Why? Because this bacteria causes shock. Whenever we have shock, we have less blood delivery to the organs. Adrenal gland is one of the sensitive organs. So because it's sensitive, it needs blood. So whenever we have a shock, decrease in blood delivery to adrenal gland, the adrenal gland would be affected, causing primary adrenal insufficiency. That's it. Just know this information. Will androgens also be low? See, now this is the thing. Androgens, okay, their levels might not be like in the normal, but it's not going to be low in a way to cause symptoms. Tamam? Why? Because there are other factors that are regulating androgens production. It's not mainly ACTH. So we can't say that androgens will be severely low and causing symptoms. But there might be a decrease in androgen levels. Tamam? But don't like be strict on this information that they're going to be decreased 100%. Tamam? Because the most important thing of ACTH is glucocorticoids. Let's move on. By the way, guys, we're almost done. So E. يلا the rest. E. So the answer is E. It's pheochromocytoma. So here we have a young patient that's presenting with, if you guys remember the 5 P's, palpitations, perspiration, pulsating headache, something related to blood pressure. I forgot all the all the 5 actually. So high blood pressure, pain, headache, perspirations, palpitations, and pallor. So here in this question, we have increase in sweating, we have palpitations, we have headaches. Tamam. So and his says that his mother and 2 cousins have a thyroid removal. Okay, so like from this scenario, we want to know that the patient is young. We knew that the patient is young, and patient is suffering from intermittent, like on and off, headaches, sweating, palpitations. تمام. So these are more leading us towards the pheochromocytoma. So pheochromocytoma, what do you need to know from pheochromocytoma? It happens in adults. The rule of 10, I'm not sure if you guys have to know this because I memorized it in third year, not in second year. But what I memorized here is that it causes intermittent symptoms, like on and off symptoms, one. Two, it causes the 5 Ps: pressure, pain, perspiration, palpitations, and pallor. Tamam? Why the intermittent effects? Because of increase in catecholamines and metanephrines. So pheochromocytoma is a tumor of the adrenal medulla resulting in increase in production of catecholamines causing these effects, which are on and off, intermittent. This is an important word. It's like, and most of the questions asking about pheochromocytoma, it's going to be there. Now, that's what I think you need to know from pheochromocytoma. Tamam? And just know that it's the disease where do they give alpha blocker before giving beta blocker. It's a must. Tamam? I'm not sure if they ask about the treatment. Do you have any questions? Or do I move on? Oh, tamam. So I'm sorry, Mariam. It took a lot of time, but it's fine. Inshallah. If you wanna go, it's fine. You can go, and then I can remind you when I'm done. Tamam. So question 19. A 46-year-old man. Okay, go ahead and answer the question, guys. Okay. B. B. Tamam, true. the correct answer is B. Now, just this is a question about a patient with type 2 diabetes mellitus, and the hemoglobin A1C is elevated. The patient was given insulin. Tamam. Now, it's simply the question is asking about just the effects of insulin. So the effects of insulin, take it from a point of view that we don't want glucose in the blood whenever we give insulin. So we're expecting gluconeogenesis to decrease. What's going to happen to glycogen synthesis? Glycogen synthesis is basically we're taking glucose and making it glycogen. So we are like kind of removing the glucose. So it's going to be increased. Glycolysis, which is basically when we utilize glucose, we utilize it in glycolysis. So it's also going to be increased to remove the glucose. Just think about it like this. So now we knew that it is decreased gluconeogenesis, increased glycogen synthesis, and increasing glycolysis. It also decreases lipolysis. Tamam? So regarding the effects, now you guys know that we have a GLUT2 receptors on the beta cells in the islets of Langerhans. GLUT2 they take up glucose. Whenever we take glucose, it enters glycolysis, resulting in the production of ATP. ATP blocks ATP sensitive potassium channels. Due to this block, it increases potassium in the cell, resulting in more positive charge, which means more depolarization, which opens the voltage-gated calcium channels, calcium influx, increase in calcium, resulting in exocytosis of insulin granules. Now, an important marker that could be released when insulin is basically released into the blood is what? Is C-peptide. And it indicates if the cause of increase in insulin, it's from outside or it's from inside. Is it basically related to an endogenous or exogenous insulin? Tamam? So whenever we have insulinoma, which is a tumor of the pancreas, resulting in increased insulin production, it also increases C-peptide production. Whenever we give sulfonylurea, which is a drug that's used for patients with diabetes, it, as far as I remember, it blocks potassium, which increases insulin production. Tamam? So it increases C-peptide as well. In type 2 diabetes mellitus, type 2 diabetes patients, there will be increased insulin production, like kind of trying to increase insulin production. So C-peptide could also be increased at the same time with insulin. Tamam? So just know the things that could increase C-peptide levels. Now, in terms of the effects of glucose, in terms of the effects on insulin, I found this diagram. It could be helpful for you guys. So if you just want to kind of go over it. And yeah, so insulin decreases lipid levels in the serum. We should know this information, tamam. So by decreasing lipolysis in adipose tissue. So now let's move on, and it increases glycogen, increases glucose uptake here in the muscles. It decreases gluconeogenesis. Tamam. So let's move on to this question. Like I skipped the function of insulin because I think you guys know it. You took it in mall and you took it again now, so no need to go over it again. Okay. By the way, guys, serum bicarb is low means that there is acidosis. Tamam. All of you are answering E. So I'll go ahead and say, yeah, it is E. So this is a patient, 16-year-old, which is most presenting with weight loss, nausea, vomiting, extreme tiredness, nausea, and vomiting. Her aunt was diagnosed with diabetes mellitus. So this type 1 diabetes, we know that it could be related to the low age, tamam. So she's 16 years old, so most likely if she has diabetes, it's going to be type 1 diabetes. Patient's urine is positive for glucose and ketones. So here we're dealing with a case of diabetic ketoacidosis. Tamam. So what's happening in diabetic ketoacidosis is that it's basically there will be an increase in the production. There will be increase in ketogenesis, which increase in production of ketone bodies, and which they are basically acids. So they will result in acidosis of the blood. Tamam. And acidosis is basically highlighted by the decrease in serum bicarb levels. Okay, so if in the exam they might not get serum bicarb is low, they might just get metabolic acidosis. So you'll be able to know that it is metabolic acidosis. Tamam. Now, why it's not A, B, C, D, and E, A, B, and C, and D? Let's go from D. Mucous membranes are moist. In patients with diabetes, especially if they reach diabetic ketoacidosis, this means that we know that one of the symptoms of diabetes is polyuria. So they're using a lot of fluid, which would lead to dehydration. So their mucous membranes, we're expecting them to be dry. Now, because they are using a lot of fluids, this would result in decrease in their blood pressure. As a result of decreased blood pressure, heart rate will be increased. Tamam? So D wrong, C wrong, A wrong. We're left with B. Now, whenever we have metabolic acidosis, I'm not sure if you guys remember from renal, whenever we have metabolic acidosis, we try to compensate. How? By removing CO2. How do we remove CO2? By hyperventilation. So hyperventilation, removing CO2, removing CO2 to kind of normalize the acid and base levels in the body. So that's why breathing pattern is going to be more, which is called Kussmaul's breathing. Tamam? So that's why B is wrong. Now, moving on to talk about diabetes, the symptoms include polydipsia, polyuria, polyphagia, weight loss. You guys know all of this. Diabetic ketoacidosis more in type 1. This hyperglycemic state more in type 2. Now, the chronic complications. Did the doctor mention anything about this part or no? He just put it in the slides. Do you guys remember? Oh, okay. So I think yes. Okay, so let me just explain it briefly. So whenever in diabetes, we have increasing glucose levels. So whenever we have increasing glucose levels, this increase in glucose levels will result in something called non-enzymatic glycation. What's happening in non-enzymatic glycation? Due to the increase in glucose levels, it goes and binds to proteins, binds to lipids. So, and this effect will result basically in kind of, how do I call it? Like it forms some molecules. These molecules will go and result in clotting, result in damaging of the vessels, damaging of the basement membranes. So as a result of an enzymatic glycation, there could be two main effects. The first one is small vessel disease. The second one is large vessel disease. In small vessel disease, they could go and result in damaging of the basement membrane, and if it's in the eye, retinopathy, in the kidneys, nephropathy. It could result in glaucoma. Tamam. So I think from here you need to know retinopathy and nephropathy. That's mainly also neuropathy. So that's why, because these molecules that I told you about, they're gonna go and damage the basement membrane, which would result in these symptoms. And large vessel disease, it causes, it increases the chance of having atherosclerosis. That's one. It could result basically in occlusions. Whenever we have occlusion of a large vessel, it could be either, for example, to the head stroke, it could be to the heart, resulting in ischemia, myocardial infarction. Lastly, to the limbs, which would cause peripheral vascular disease. Tamam? This is the non-enzymatic glycation. We have another effect, is that osmotic damage, sorbitol accumulation. Now, whenever we have high glucose, it will be taken up by certain cells. When it's taken by by cells, glucose is going to be converted to sorbitol, tamam, with aldose reductase. Sorbitol will be converted to something else. I'm not sure what is the name, but by an enzyme called sorbitol dehydrogenase. So the whole message from this is that we don't want sorbitol to accumulate, because whenever sorbitol accumulates, causes problems. Tamam? So when we have high glucose, get taken up by cells, accumulates, this glucose will be converted to sorbitol. Now, in some cells, they will be sorbitol will be removed by sorbitol dehydrogenase, but in some of the other cells, they don't have sorbitol dehydrogenase, so sorbitol accumulates. Whenever we have sorbitol accumulation, it would cause some symptoms. These symptoms are happening because sorbitol, like it kind of increases the osmolality, which causes more fluid. It drags more fluid, resulting in kind of rupture of the cells and damage. So this would result basically in cataract and neuropathy. That's why it's called osmotic damage that's related to sorbitol accumulation. Tamam? Yeah, inshallah, guys, you don't have. I'm not sure if you have to know this or no, actually, because this is like it's third year stuff. It's not physiology. It's pathology. But I just gave you an overall idea about it. Now, whenever we're here, now I'm gonna try to simplify it a bit. So whenever we have insulin deficiency, this means that we have high glucose. High glucose leads to high osmolality. Whenever we have high osmolality, it will result in the sensation of the osmoreceptors in our body. Due to this sensation, this increases thirst. Why? So that we go and drink water, so that we normalize the osmolality. Tamam. At the same time, because it increases the osmolality, it also causes osmotic diuresis. Why is this the case? Because high glucose will go to the kidney, goes to the tubules. Whenever we have high glucose in the tubules and in the urine, it drags more water, resulting in polyuria. So due to this, it will result in loss of fluid, resulting in hypovolemia, loss of electrolytes. Due to the hypovolemia, there might be some coma and death. Tamam? Now we kind of knew this. Now here we come to polyphagia. A symptom of diabetes is polyphagia, which is basically increase in the appetite, or like increase in appetite mainly. Why does it happen? It happens because there is an increase in the degradation of proteins, which would cause polyphagia. Tamam? Also, whenever we have insulin deficiency, I told you we have ketogenesis, increase in ketones. Tamam? So increase in ketogenesis results in keto acids production. Keto acids production resulting in vomiting, and it also causes acidosis. Due to the acidosis, we try to compensate by hyperventilation to remove the carbon dioxide. By removing carbon dioxide, which is acid, we normalize the metabolic acidosis. Tamam? This is called Kussmaul's respiration. Tamam? This is the main pathway of metabolic acidosis. Now here we said there will be hypovolemia, which means that blood pressure will be low. So whenever we have low blood pressure, which is going all the way to the organs and the tissues, due to the hypoperfusion of the tissues, there will be increase in the cell damage. Due to the increase in cell damage, there will be increase in lactic acid production. which would cause lactic acidosis and contributes to metabolic acidosis. This is like a kind of a simple explanation of the this diagram. تمام. I'm not sure if you guys have to know all of these stuff, but it's just a simple explanation. Now, to talk about type 1 diabetes, type 1 diabetes happens in younger patients, less than 30. Type 2 happens in more than 40 in elderlies, or in adults and elderlies mainly. It happens due to insulin resistance, while this one due to autoimmune destruction. تمام. This one is related to HLA DR4 and DR3. This one is related more towards the it could be related to the genetics as well. What do we need to know from here? Okay, so ketoacidosis are more in type 1. That's why diabetic ketoacidosis is more seen in type 1 diabetes, okay? Because even though in type 2 diabetes there is insulin resistance, however, there is enough insulin to prevent diabetic ketoacidosis. However, in type 1, there's no insulin at all. So there's no insulin to prevent diabetic ketoacidosis. That's why it happens a lot. Yeah, that's mainly it. Other things are mainly related to pathology. So let's talk about diabetic ketoacidosis, or let me tell you something. I'm just gonna skip this slide, answer this question, and I'm gonna go back to the previous slide. So if you can answer this question. Okay, so Jana and Ahmed, try to look at the age, look at the type of diabetes, look at the level of blood glucose and the serum osmolality. Yeah. Make sure about this stuff. So the guys that are with us in the guys, what do you think? Okay, B, we've got another B. Yalla, some more B's. Okay, so the answer is B. So this is a patient, 58-year-old male with a known history of type 2 diabetes. So we know it's a male with type 2 diabetes. Okay, so presenting with extreme thirst, something significant. The blood pressure is high, heart rate is okay, respiratory rate is high as well. Temperature, laboratory results reveal a blood glucose of 650, serum osmolality is 350. Which of the following mechanisms is most likely causing the symptoms in this patient? So, guys, the answer is B. But in this kind of patient, we can expect that there might be some ketogenesis, right? Even though it's not type 1 diabetes, there might be some ketogenesis because the symptoms are so severe. Maybe there might be some diabetic ketoacidosis, tamam, but the things that it is basically resulting in the symptoms of this patient, which they are the extreme thirst and the frequent urination, are the increase in the glucose levels, which basically increase the osmolality in the urine, dragging more water into the urine, resulting in polyuria. So this is what's called osmotic diuresis, tamam. So hyperosmolar hyperglycemic state, HHS, it's happening as a result of, it's basically the markers of it are increase in serum blood glucose more than 600, increase in serum osmolality more than, I think, 320, which are causing extreme thirst and frequent urination. This is an expected symptom of diabetes mellitus, right? Yeah. We can expect patients with diabetes to have polyuria and polydipsia. That's true. But let me tell you why it's leading us more towards B. Now, we all agree that it's not going to be D, and okay. So, and it's not going to be E. Why? Because these symptoms are severe. Whenever we have kidney disease due to diabetes, sometimes it takes some time. Okay. So let's just focus on A, B, and C. Now, I told you that these patients might have ketogenesis, might have some ketogenesis because of the diabetes that they have. However, it's less likely to be there in patients type 2 diabetes mellitus. Tamam? Even diabetic ketoacidosis, it's less likely to be in these patients. Tamam? However, it might be there. But why did I say that it is? The answer is B, is because this patient has type 2 diabetes mellitus. Tamam? Presenting to the emergency department with complaints of thirst and frequent urination. So there is something that happened that resulted in the patient to present. Tamam? So it's something that's acute. And that's happening only for 2 days. He reports a recent respiratory tract infection. So that's a stressor. Tamam? So whenever we have a stressor in our body, we need more insulin in our body. Tamam? Like there will be more glucose, so we will be needing more and more insulin. Because in type 2 diabetes mellitus, there will be insulin resistance. So we have higher levels of glucose, but the insulin resistance is still there. So blood glucose levels are just increasing until it reaches 650. Cause the serum osmolality more than 320. That's basically a typical presentation of hyperosmolar hyperglycemic state. Tamam? Which is basically what's the reason causing this symptom is basically these symptoms are osmotic diuresis. Jana, did I explain well, or do you want me to repeat again?
So we're saying that because of the infection, his body's under stress, which exacerbates the diabetes symptoms, causing osmotic diuresis.
Exactly. So it's usually these symptoms usually happen whenever there is a stressor on the patient. For example, the patient there's an infection, maybe delivery, because like baby delivery could be a stressor as well, trauma, and these kinds of things. So these would increase basically our need for insulin because there will be elevated levels of glucose. And one more thing that would explain that why is this hyperosmolar hyperglycemic state is because the blood glucose is more than 600 and serum osmolality is more than 320. These are two like key and hallmarks of the hyperosmolar hyperglycemic state. Tamam?
Yeah, crystal clear. Thank you.
You get it?
Yeah.
Also in type 2 patients with type 2 diabetes, don't think too much about diabetic ketoacidosis and ketogenesis because they are most likely related to type 1 diabetes. Tamam?
Yeah.
Here, by just looking at the answers, you can just eliminate them and just choose B. For everyone else, is it clear? Yeah. Okay, we have a yes. Yep. Tamam. Okay, I told you I'm going to go back and explain this. Let me just go back quickly. So here in diabetic ketoacidosis, due to the increase in the requirements, insulin non-compliance to the like these patients, if they are not taking their insulin injections, or there will be an increase in the requirement of insulin, which is in the case of stress. In these patients, there will be increase in ketone bodies formation. Tamam? So there will be insulin deficiency and ketone body, resulting in ketoacidosis. Symptoms of ketoacidosis could include delirium, cross-modes breathing. Why? Because we're trying to compensate for the acidosis. And nausea, vomiting. Why? Due to the acidosis and due to the keto acids levels. Here, okay. Tamam. I think we explained this. Did he talk anything about, did Dr. Yaqin talk about potassium levels? Okay, so I'm just going to tell you an information about potassium. Insulin has an effect of potassium. What is the effect of insulin on potassium? Is that insulin causes potassium to move from outside the cell into inside the cell. تمام. So that's the effect of insulin. Okay, so insulin causes potassium to enter the cell. That's the main effect of insulin. تمام. Okay. So I believe you guys should, like you should know this about potassium. Like he might tell you, like a question is telling you which of the following might be the effects of insulin, and all the answers are wrong. The only answer is increasing in the intracellular levels of potassium. You choose this answer. تمام. For hyperosmolar hyperglycemic state, whenever we have profound hyperglycemia that could happen due to stress, there will be increase in osmotic diuresis, which could explain why there will be hyperglycemia, because we have more glucose now and less insulin to compensate for to remove all of this glucose. It can't remove all of this glucose due to like the insulin resistance and all these stuff that are happening in type 2 diabetes. So there will be glucose levels are going to be more than 600. Osmolality is going to be more than 320. Whenever you see these two in the same question, inshallah, it's 100% hyperosmolar hyperglycemic state. What does it cause? It causes osmotic diuresis. Tamam? And one important feature to know is that in hyperosmolar hyperglycemic state, we don't have ketones. Like whenever we measure ketones, they're not going to be there in the urine. However, in diabetic ketoacidosis, we're going to measure ketones and they're going to be there. And whenever there's a question, they're going to tell you that this patient has acidosis, nausea, vomiting. They will tell you like the symptoms of delirium, tamam, abdominal pain, and they measured urine ketones and they were positive. So this is more towards diabetic ketoacidosis. Do you guys like now know how to differentiate between diabetic ketoacidosis and hyperosmolar hyperglycemic state? So whenever we see a question about diabetes mellitus, we look at the age, we look at the type of diabetes, and then we look at the symptoms. We also look at the labs. The labs, whenever we see ketone positive, diabetic ketoacidosis. Whenever we say hyperglycemia more than 600 and osmolarity, serum osmolarity more than 320, hyperosmolar hyperglycemic state. Tamam? Are we clear on the same page? Yeah. And here we go. Finally. I'm so sorry, guys, if it took so long. I actually anticipated that it could take like maximum of 2 hours, but inshallah, it was beneficial. And I wish you all the best of luck in your exam. And one more thing, don't be stressed or don't be worried at all if the questions were not easy. Okay, so the reason I brought this question is not to test you at all. I just brought them for you to understand how to approach a question. Tamam? So just go back to the recording if you want to understand any of the questions. Also, I put explanation under each of the questions. So the source of the question and the explanation. So if you don't want to go back and hear my voice. So, tamam? Any questions about anything, about about these questions that I put, about the exam, about whatever, any questions? Nope, all good. Tamam. I think Mariam, we can stop the recording. Thank you so much for your help.